Hi, my name is Estefania Zuluaga. I'm a physical therapy student at UCF. Today I'll be performing manual muscle testing, range of motion, and muscle length testing. The patient will have the arm resting on the table with the thumb pointing up. The therapist will then stabilize the hand and apply counter pressure at the first metacarpal and the proximal phalanx. We will be testing extension of the IP joint of the thumb. So the patient will have their thumb in extension, and the therapist will be applying pressure against the dorsal surface of the IP joint of the thumb in the direction of flexion. The patient will now hold this position for 5 seconds. 1, 2, 3, 4, 5. Since the patient was able to hold the position for 5 seconds against strong pressure, the patient would receive a 5 out of 5 grading. The patient will now have their arm with the palm facing down. The therapist will stabilize at the wrist, avoiding full extension. We were going to be testing the extension of the MCP joint of the second digit with the IP joint relaxed. The pressure is going to be against the dorsal surface of the proximal phalanx in the direction of flexion. We will place the proximal phalanx in extension and have the patient hold this position. I will now be applying strong pressure for 5 seconds. Ready? 1, 2, 3, 4, 5. The patient was able to hold extended position against strong pressure in the direction of flexion for 5 seconds, therefore we would grade him with 5 out of 5. The patient is now in the neutral position in order to allow for a second PIP flexion. I'll be using a finger goniometer. The axis will be placed on the dorsal surface of the PIP. The stationary arm will be parallel to the longitudinal axis of the proximal phalanx, and the movable arm will be parallel to the longitudinal axis of the middle phalanx. The normal value for PIP flexion is 100 degrees. I am stabilizing at the proximal phalanx. I will now have my patient do an active range of motion at the PIP flexion. I have to make sure also that I am not having my thumb be in the way while she is flexing. Now I'm getting a reading of 92 degrees. Being that the normal value is 100 degrees, the 92 degrees is a normal value. The patient's arm will be in the neutral position. We will be using a finger goniometer to measure the DIP extension of the second digit. This is our stationary arm, our axis, and our movable arm. The axis will be placed over the anterior surface of the DIP. The stationary arm will be parallel to the longitudinal axis of the middle phalanx, and the movable arm will be parallel to the longitudinal axis of the distal phalanx. The normal value for DIP extension is going to be 0 degrees. I will now perform this test on the patient. Making sure that I stabilize the middle phalanx, I will have the patient go into active range of motion of PIP extension. I am now getting 2 degrees of hyperextension. Although the patient got 2 degrees of hyperextension for her DIP extension, it is still within the normal range of 0 degrees of extension for the DIP. I will now be performing a passive range of motion of wrist flexion in order to compare it to my later value for the muscle length test. I'll be using a goniometer to measure the wrist flexion. The axis will be placed at the ulnar styloid process. The stationary arm will be parallel to the longitudinal axis of the ulna, and the movable arm will be parallel to the longitudinal axis of the fifth metacarpal. It will all be in passive range of motion, and I will be stabilizing at the distal forearm. The fingers must also be relaxed, and the hand must be off the table in order to allow for wrist flexion. The patient has 80 degrees of wrist flexion, and seeing that the normal value is 80 degrees, she falls within the normal value. I will now be performing a manual muscle length test of the extensor digitorum. The patient has the elbow extended, the forearm pronated, the wrist neutral, the fingers flexed, all to allow for the extensors to be lengthened over all the joints except for the wrist. I will be using the goniometer to compare it to my earlier value from wrist flexion. I will be using the same landmarks for the ulnar styloid process as the axis. The stationary arm will be parallel to the longitudinal axis of the ulna, and the movable arm will be parallel to the longitudinal axis of the fifth metacarpal. I will now place the patient in passive range of motion of wrist flexion, and I will be stabilizing at the distal forearm. The patient has a reading of 75 degrees. Since the patient had 75 degrees value of passive range of motion of wrist flexion during the extensor muscle length test, we can conclude that there was shortening of the extensor muscles